So now let's talk about the mitral stenosis. Here's a brain trainer. Okay, a man presented with a shortness of breath on mild exertion since he returned from Gambia 2 months ago. Chest X-ray shows a sharp, straight heart border. Okay, shortness of breath, mild exertion, returned from Gambia 2 months ago. Chest X-ray shows a sharp, straight heart border. There is a mid-diastolic murmur at the apex. Mid-diastolic murmur at the apex. What is the most likely diagnosis? So if the murmur is audible at the apex, so there will be two. It could be stenosis, mitral stenosis or mitral regurgitation, but as it is a diastolic murmur at the apex, and so it is mitral stenosis. Okay. So here is another question on mitral stenosis. A man presented a shortness of breath on mild exercise. He returned from South Africa months ago. An echocardiogram reveals a narrowing of the total area of the mitral valve. What long-term complication is this condition associated with? So a stroke. Okay, mitral valve stenosis will increase left atrial pressure, which will cause left atrial hypertrophy, and left atrial hypertrophy may lead to atrial fibrillation, and that atrial fibrillation may cause venous thromboembolism, could be the cause of cerebral infarction. Okay, and so it will ultimately lead to a stroke. Okay, so now let's talk about the cardiomyopathies. Okay, dilated, hypertrophic, and restrictive. Okay, and so in dilated cardiomyopathy, it can be seen in alcoholic patients, viral myocarditis, and a patient on doxorubicin. Okay, and there will be diastolic murmur. Okay, and patient may present with heart failure, and there will be S3 heart sound audible. Okay, and treatment is ACE inhibitor, beta blocker, diuretics, and digoxin. Okay, it's all about the dilated cardiomyopathy. And if we talk about hypertrophic cardiomyopathy, it will be associated with autosomal dominant mutation, and in this there will be diastolic murmur. Okay, and syncope during exercise. Patient present with syncope during exercise, and sudden ventricular may present with sudden ventricular arrhythmia, and treatment is beta blocker or calcium channel blocker. Okay, ICD for arrhythmias. And if patient present with restrictive cardiomyopathy, restrictive is associated with amyloidosis, sarcoidosis, and post-radiation fibrosis. Okay, and this there will be diastolic murmur, and complication right-sided patient may present with right-sided symptom like edema and ascites. Okay, and dyspnea, and treatment is diuretics. Okay, so hope it is clear till now. So in dilated, and there will be alcohol, viral, and doxorubicin. In hypertrophic, there will be autosomal dominant mutation, and in restrictive, there will be amyloidosis, sarcoidosis, and prostration. Okay. So now let's talk about the AV conduction block. So first degree AV block. In first degree AV block, there will be prolongation of PR interval more than 200 milliseconds square, and this no treatment is required. Okay, there will be only prolongation of PR interval. You can see here rest rate and rhythm is normal. Okay, so no treatment is required. But we talk about second degree AV block, and there are two second degree AV blocks, Mobitz type 1 and Mobitz type 2. Okay, so in Mobitz type 1, there will be PR interval lengthen progressively until a beat is missed. R interval is variable. Okay, and symptomatic, there will be symptomatic bradycardia, which can be treated with atropine. Okay, so you can see here PR interval lengthens. Okay, and then there is a missed beat. You can see here there is a missed beat. So P were absent, QRS. Okay, so you can treat this patient with Mobitz type 1 with atropine. Okay, only one missed beat. But if you talk about morbid type 2, so in morbid type 2, PR interval is regular, and dropped beat and QRS complexes. Okay, so it's regular, but there are dropped beats, QRS complexes. Okay, and so say there will be symptomatic bradycardia, and treat with atropine initially, but appropriate treatment is with the pacemaker. Okay, so if patient present with type 1, treatment is atropine. If patient present with type 2, so treat initially with atropine. Okay, as patient is symptomatic bradycardia, so we will first treat patients bradycardia, and then definitive treatment is pacemaker in morbid 2. Okay, and here is a difference between morbid 1 and 2 memory aid. A good memory tool to differentiate morbid type 1 and 2 is the analog of the late husband, you can say. Okay, so P is a wife and R is a husband. Okay, so husband represents the QRS complex and the wife represents the P. Okay, so in type 1, the husband comes home later and later every day, hence longer PR intervals before he does not come home completely, so dropped QRS complex. Okay, and in type 2, the husband comes home on time every day until suddenly he decides not to come home anymore without any warning sign. This is the reason type 2 is more dangerous. Okay, so it's all about their marriage. And if they had some conflicts, like some misunderstanding, then husband was angry, and he used to come home late every day. Okay, and it's all about that. Before he does not come home completely, drop QRS complex. Okay, and in type 2, the husband comes on the time every day, and when everything was right, but then suddenly he decides not to come home anymore without any warning sign. So this is a reason type 2 is more dangerous. Okay, so it's all about the type 1 and type 2. So their marriage is the risk. Okay, first he was angry, he was coming late, and 2, he decided not to come home, so it's type 2. Okay, and let's talk about the AV conduction block. Third degree AV block is complete. So you can say, like, there was quarrel between them, and he decided not to come home, and then they divorced. So divorced is like a third degree AV block. So atrial and ventricles contract independently because they are divorced, so they didn't care about themselves and each other. They didn't care about each other. So no association between the P, which is wife wave, and QRS complex, which is husband. So there is no association between them because they are divorced. So causes could be myocardial infarction and Lyme disease. Okay. So immediate treatment is atropine 500 mg IV followed by transcutaneous pacing, but definitive treatment is pacemaker. Okay, so pacemaker is treatment for morbid type 2 and complete AV heart block. Okay, so it is about the third degree. Okay, so now let's talk about AV conduction block. All symptomatic bradycardia despite rhythm. If patient is present with symptomatic bradycardia despite rhythm, start atropine. Okay, stabilize the rate first. Okay, and then there is a bradycardia algorithm. Any adverse feature? If yes, then like adverse features like patient in shock, syncope, myocardial infarction, or heart failure. If yes, if any one of them, then go for atropine intravenously. and if there is good response with atropine, and then check the risk of AS systole. Example include MOBITS 2 AV block, complete heart block, and a broad QRX. If these are available, then consider repeating atropine or other drugs or transcutaneous pacing, and go for arrange permanent. And then if you have done all these things, so arrange a permanent pacemaker. Okay. And if patient has feature any of like shock, syncope, myocardial, or heart failure, and you have given intravenous atropine, and there is and you have checked for good response. If there is no good response, then consider repeating atropine or other drug or transcutaneous pacing. And once these are done, then arrange permanent pacemaker. Okay. So ultimately, if patients presented with features of bradycardia, then you have to give atropine, you have to check the response. Okay. And ultimately you will advise transcutaneous pacing or repeating atropine if required, and definitive treatment is permanent pacemaker. Okay. But if a patient do not have any features, okay, a patient presents with bradycardia but no feature of shock, syncope, myocardial infarction, or heart failure, so first you should check for the risk of systole. Example, if in an ECG there is MOBITS 2 AV block, a complete heart block, and broad QRX, and if yes, then again consider repeating atropine or other drugs or transcutaneous pacing, and arrange permanent pacemaker. Okay. So ultimately I'll have to go under permanent pacemaker. Okay. So now let's talk about the AV conduction block memory aid. In any event that a patient has symptomatic bradycardia, atropine is your first initial management. Okay. And after that, temporary pacing becomes the most appropriate next step in management. In patients with adverse effects from bradycardia who do not respond to atropine or have MOBITS type 2 or complete heart blocks with wide QRS. Okay. First, stabilize the heart rate, atropine, then a temporary pacing becomes the most appropriate. Okay. So definitive management in a non-urgent situation. So first and second type, no treatment, and second degree type 2 and third degree pacemaker is required. So if patient present with first degree AV block and second degree AV block, no further treatment. But if patient present with first degree AV block, no further treatment. But if patient present in second degree AV block, but he is in MOBITS type 1, then no further treatment. But if patient presents with second degree MOBITS 2, then pacemaker. Okay. And if patient presents with third degree AV block, then again pacemaker is a definitive treatment. So in first degree AV block and second degree MOBITS type 1, no treatment is required. But in second degree MOBITS type 2 and third degree AV block, pacemaker is the permanent treatment. Okay, so now let's talk about the antiarrhythmic medications, type, use, and side effects. And so class 1 is sodium channel blocker. Okay, and so its uses quinidine and lidocaine, atrial and ventricular arrhythmias. Okay, and its side effects are synchronism, headache, and tinnitus. Okay, and in class 2 is beta blocker. Okay, metoprolol, which is used in SVT. Okay, rate control for atrial fibrillation and atrial flutter. Okay, and side effects are exacerbation of COPD and asthma and AV block. So you should be cautious about before prescribing these things to patient with asthma, COPD, or with already AV block. Okay, and class 3 is a potassium channel blocker. Okay, class 3 includes amiodarone, which is used in ventricular tachycardia. Okay, and side effects of amiodarone are pulmonary fibrosis, hepatotoxicity, hypothyroidism, and corneal deposits. Okay, and sotalol and Abutylite causes TARS T-pointis. Okay, and the treatment for TARS T-pointis is magnesium sulfate. Okay, I hope I made easy for you. Okay, so SPP, you can remember SPP. Okay, S for class 1, S, class 2B, and class CP. Okay, SPP. So S for sodium channel blocker, and class 2 beta blocker, and class 3 potassium channel blocker. So SBP. Okay. So it's all about the antiarrhythmic medications, and let's talk about the class 4 CCB. Okay, and so it's so SPPCO, class 4 calcium channel blockers, and O for